Hello, everyone. A very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I would like to begin by acknowledging the Ngunnawal and Ngambri people, who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from. And I pay my respects to their elders past and present. We're pleased to welcome attendees from various parts of Australia and the globe, including India, Indonesia, Burma, Fiji, China, and South Africa. Knowledge is power, and our weekly webinar series allow us to share and learn from each other's experience during the pandemic. Today, we have a very exciting speaker, Dr. Brett Scholz, and a very important topic, which I'll both introduce you shortly. I am Devashi, a medical student and volunteer for the ANU COVID-19 Peer Support Program. And joining me are my colleagues, Bridget Nielsen and Hannah Grick, who are both ANU medical student volunteers as well, and Dr. Deepthi Talalekar, who is a clinical hematologist and the program lead for the ANU COVID-19 Peer Support Program. Before we begin the webinar, just quickly a couple of housekeeping notes. All attendees have their videos and microphones switched off, and this just helps us keep the sound quality clear and reduce interference during the webinar. I encourage all attendees to ask questions. That's the best way we can interact with each other virtually. And to do so, please use the Q&A button down at the bottom of your screen. If you do not wish to be identified, you can submit these questions anonymously. And you can submit these questions at any time during the presentation. There will be a webinar rating poll that will pop up on your screen towards the end of the talk. So please do select your preferred response. It just helps us with the monitoring and evaluation of the program. And I assure you that all responses will be recorded anonymously. If you have any technical issues or questions after the talk, please email international.health@anu.edu.au, and we will try to assist you as best as we can. And finally, please note that this forum is being recorded. On to today's webinar. This webinar will be delivered by Dr. Brett Scholz on partnering with service users in the COVID response. And he will be discussing the principles of collaboration with service users and how it is applicable in the context of COVID-19. He will also discuss the benefits of and his learnings from running the service user engagement strategy used in the Australian Capital Territory to develop the ICU triage process for COVID-19. So Dr. Brett is a senior research fellow at the ANU Medical School, and more than 47 of his 74 publications are co-produced with or led by service users or people with lived experiences of the research topic. As a critical health psychologist, his research mostly focuses on ways health and health services can challenge power norms, be more equitable, and be led by consumers. He has held various positions in a wide range of health disciplines and areas, and using them all to champion co-production with consumers. In his spare time, he loves singing karaoke and watching Malayalam cinema. Wow, Brett, you've got to give me Malayalam movie recommendations. Excellent. We also have two amazing panelists on board today. We have Darlene Cox, who is the Executive Director of Healthcare Consumers Association, ACT. And we also have Anthony Brown, who is the Executive Director of Health Consumers, NSW. And I'll leave it to Brett to introduce them properly. So with this, let's begin the webinar itself. Over to you, Brett.
Well, thank you so much, Devashi, for that introduction. I'm really excited to be speaking to you all tonight. I'm joining you from Ngunnawal country in the Australian Capital Territory, and it's very exciting to be part of this very international event. I did wonder, given it's Diwali this week, whether people would still be able to join us, but it's lovely to see people attending from near and far. So welcome, and I hope that you enjoy. As Devashi introduced, I'm joined by two phenomenal panelists, Darlene Cox and Anthony Brown, and they will give a little bit more of an overview after I've spoken. I'm going to lead the first part of the talk, so I might get that kicked off and then introduce the panelists as we move through each presentation. As you know, I'm going to be speaking tonight about we all are speaking tonight about consumer engagement in the COVID-19 response. And it struck me as I was preparing these slides that given that we do have such an international group of attendees, that it's probably worth a brief note on language use. So I use the term consumer, which is the term that's most commonly used throughout Australia in reference to health service users, patients, people with lived experience. There's a lot of different terms that are used in other jurisdictions and other contexts. So just to be clear, I'll keep using the word consumer as that's what's most commonly used in Australia and what comes to mind quite quickly. But I do acknowledge that the language in the area is contentious and that not everybody likes the word consumer for various reasons. But that's not the point of what we're talking about today. We're going to be talking about consumer engagement in the COVID-19 response. In the first part of the talk, I'm going to be discussing about how here in the ACT, in the Australian Capital Territory, we involved consumers in the development of the triage process in the context of ICU in COVID. And Anthony and Darlene will talk a little bit more about the broader context and the ways that consumers were involved in the responses in New South Wales and the Australian Capital Territory, respectively. Before I get stuck into talking about the triage, I do want to briefly talk a little bit about why my work is informed by consumer leadership and what that means. So consumer leadership, everything that I'm interested in a health system, health policy, health research, and health education that's led by consumers. Consumer leadership itself is a term that is still not super well defined within the literature, but essentially consumer leadership relates to application of lived experience as a service user or patient or a consumer of health services. It involves influencing service design or delivery. It involves collaborative practices or connections with others, and it promotes a culture of inclusion and support, particularly for other consumers engaged with health services and system. That's a really brief overview, but I know lots of people are conducting further research into exactly how to define consumer leadership and what that means in practice. But that's just a little taste of what I would like to see the health system based on. You may be familiar with various forms of participatory approaches in health. And so I see consumer leadership as moving towards being a health system and health services that are controlled by consumers or citizens. But you're probably familiar with lots of other participatory approaches as well. And I've got Arnstein's ladder here of citizen control. And you can see as you move up the ladder towards citizen control, there's various ways in which citizens are involved in this context in health system. And it's if you haven't come across that before, you may well have. It's not an uncommon, concept, but if you haven't come across it, it is a good read to have a look at Arnstein's ladder. I guess also, if you'll just indulge me very briefly talking about why I became interested in this and just an opportunity to talk about myself for a moment. In about 2015, I started working in a research centre that, alongside me, I don't identify as a consumer. I'm a critical health psychologist by background, but I worked in a research centre that had a dedicated role for a consumer researcher. So a full-time researcher, just like me, but who came from a consumer or lived experience perspective. And for a number of years, everything that we published, all of the grants that we applied for, all of the teaching that we did, everything we did was meaningfully co-produced. So actually from start to finish, done involving consumers as well as non-consumers like myself. And that's when I realized the value and how much value it meant to be able to actually co-author every single paper with a consumer or deliver a lecture with a consumer. So that's how I got interested in the area. As I've just mentioned, co-production is something that I always seek to work towards. So co-production involves collaboration at every stage of a project. This reference that I've got here on the slide is itself co-produced by consumer academics and non-consumer public servants. I really like it, and I keep coming back to this reference every time I do something collaborative with consumers to remind myself of the importance of actually collaborating at every stage of a project. And we can't call something co-production if we're not actually involving co-planning before the start of a project, co-designing throughout the project, co-delivering it, and then at the end, co-evaluating it. Again, that's just a really brief taster, and I could probably talk for hours about those ideas. But I guess why that's important and why I'm bringing that up today before I start talking about what we did with the triage process in the ACT is that I really wanted to, with the triage process that I'm about to, and I'm very excited to start talking to you about in a moment, I really wanted to try and work towards these principles of co-production, which, in some ways, I'm currently evaluating what we did, and in some ways we did achieve some of the principles, and in other ways we didn't achieve all of these principles, but I see it as a process of working towards always co-producing with consumers whenever possible, and I encourage everyone to have a read of that reference and everything that's cited in that reference, because this is my little co-production Bible and is a really accessible way of thinking about co-production. Okay, really briefly, I'm going to mention a couple of benefits of co-production, or at the very least, collaboration with consumers in everything we do in health policy, health services, health education, and health research. So some of the benefits include social justice, which is why I've chosen this image of a social justice icon. There's other benefits as well. Services that are actually co-produced with consumers are more reliable. They're more relevant to consumers. They're safer. If we're actually meaningfully co-producing health systems with consumers, then we know that we can minimize services that are not relevant or not important for consumers and better spend our efforts on providing services that actually are relevant to and meaningful for consumers. There's many other benefits as well, but I really just wanted to give a taster, and in the interest of time, I'm going to briefly move on and just mention a few of the challenges to meaningful co-production with consumers that I've experienced or seen. So the first barrier to co-production with consumers is stigma. It's definitely a paradigm shift for many people in the health system to actually collaborate with consumers as equals. There's a lot of stigma, and there's assumptions that consumers lack capacity that non-consumers in the health system have. That can often lead to another barrier, which is tokenism. Consumers are often relegated to roles that do not share power, do not actually involve decision-making or agenda-setting roles. And I guess the last barrier that I'll mention, which underlies both of those two others that I've just mentioned, is that there's power imbalances. So whenever consumers are engaged in projects with other stakeholders in the health system, so health professionals, non-consumer health professionals, there's often power imbalances related to that stigma and tokenism as well. Okay, that was my very brief overview of some of the background to engaging with consumers. Now I want to move on to speaking specifically about in the COVID response and my experience in collaborating with consumers to work together to develop the principles underlying the triage process for ICU in the context of COVID here in the Australian Capital Territory. So essentially in about March, I think it was, of 2020, I got a phone call from the clinical director of the COVID-19 task force here in Canberra, who said she really wanted to see a triage process for ICU developed together with consumers. This was a colleague of mine that I'd worked together with for various years, and I was always impressing upon her the importance of doing whatever we do with consumers. And she was somebody who was well aware of the values that really meaningful collaboration with consumers could bring. So it was great to get that phone call. She did say at the time, it may well be 7 days a week of work. We don't know when COVID is going to hit Canberra, and we don't know when we're going to need a triage process for ICU. So it was quite daunting, but at the same time, really important. And I was really pleased to see that there was a commitment to collaborating with consumers at that level and at that stage when we didn't really know what was going on. At the time, both Healthcare Consumers ACT and Health Consumers New South Wales had recently put out sort of some guides about how to collaborate with consumers in the COVID response. So I drew both on Anthony's and Darlene's sort of documents that they had put together, and spent a number of months in the end developing this triage process. I guess it's worth saying that in Australia, the impact of COVID was was potentially, we had a lot more time to set up systems than some other countries. And so it was difficult, but it was a privilege to be able to have that time to meaningfully collaborate with consumers and develop processes for triage. So how we made it happen? Well, as I mentioned, clinical director of the COVID-19 task force wanted it to happen. I've written a little bit about how allies or people who are not consumers, but who can use their positions of power to make space for consumers to be engaged, and engaging acts of allyship can help to really make these things happen. I think the fact that there was a senior clinical director who wanted to make it happen and wanted to make collaboration happen to develop an ICU triage was a key driver in this. There was already active partnerships between consumer advocacy bodies and health institutions. So Darlene will speak about this a bit more, I think, but within the Australian Capital Territory, Healthcare Consumers ACT and various other consumer advocacy and peak bodies within the Territory have some existing excellent partnerships with a range of health institutions and institutions more broadly. And so having those existing partnerships helped make things happen a little bit more smoothly than would have otherwise, I think, been the case. There were resources for this to actually happen. So as part of my job, and sometimes it was working 7 days a week to make this happen. Obviously, that's a lot of time and resources, but obviously without resources, actual collaboration is very difficult to make happen. I'm not going to go into tons and tons of details in the interest of time, but in my opinion, the outcome of this process had many positives. So in the end, by involving, I think it was 26 consumer, carer and community organisations in a process of collaborating to work out the principles that would underpin triage, it was absolutely transformed. So the initial idea of what a triage process for ICU would look like in the context of COVID so originally the idea of what that would look like based on health professionals' input was very different to what the end product looked like after consumers, carers and community members got to input and reshape and reform the idea of a triage process. Fundamentally, we ended up with a triage process that was based on human rights principle. And that wasn't what the original idea of what a triage process would look like when we just spoke to health professionals rather than consumers. So for me, that was incredibly transformational and incredibly important. And in fact, I've recently seen in some other jurisdictions in Australia that the triage processes were, in the end, fairly discriminatory in some ways. I don't know if this is true or not, but I saw on Twitter recently that some health professionals were told that if consumers needed to be triaged for ICU care, that there would be an age cutoff of 72 or something like that. Again, this is just from Twitter and it's unfounded, so I don't know if it's true or not. But it was really pleasing to see that here in the Australian Capital Territory, we had a system where that kind of discrimination based on age was against the triage that we developed. And last of all, we built in safeguards to meet consumers' needs so that discrimination couldn't happen. There were things like, for this triage process, all ICU staff would have to have unconscious bias training and would have to be aware of what discrimination and human rights principles actually look like. So there's definitely in some ways I might be making it seem like it was all really easy and straightforward by just saying some of the positives. By including 26 different consumer care and community organisations, there were definitely different views and dissensus, and I don't necessarily have time to go into all of that. But I just wanted to make the point that I think the final outcome was actually really positive compared to what a triage process for ICU might have looked like. Okay, I'm just going to leave with 3 takeaway points before
Brett.
Yes.
Hi, Brett. Sorry to interrupt you. One of the attendees has asked a really good question. I think it would be good if we clarify it early. So Emma has asked, can you explain what you mean by triage in ICU, please? Thank you.
Yes, and my apologies. I realise that is absolutely key. So I'm sorry that I didn't mention this before. So ICU, I'm talking about intensive care units, and specifically when I'm talking about ICU in the context of COVID, I'm talking about manual ventilation. So going on a ventilator for supported breathing for those people who are having quite severe COVID, having quite a severe acute COVID symptoms. And when I'm talking about triage, I'm talking about sorting into those who would receive ventilation and those who would not receive ventilation. And to be even more specific, I guess the concern was, in the context of COVID, what we were seeing happen in a lot of other countries like Italy and the United States was that demand for ventilation by far exceeded capacity. And we were a little bit scared that in Australia we might get to that same into a similar situation where we would not have enough ventilators, but also staff to manage those ventilators for patients. So yes, thank you, and apologies again for not clarifying that earlier. Absolutely my fault. I have three takeaway things that I would like to leave you with. I guess a couple of lessons that I learned through this process that I think made consumer engagement in the context of COVID a little bit easier. And the first is that we had to provide multiple ways and multiple times and multiple opportunities for 26 different consumer carer and community groups to be able to engage meaningfully. It wasn't particularly, early on in COVID, we were only able to contact and speak via Zoom or via email and not face-to-face, which sort of limited the ability of having multiple ways to influence. But, in the end, trying to ensure that we had one-on-one Zooms available, forum Zooms available, ability to have a phone conversation or email was absolutely key. My second takeaway that I've chosen to sort of exemplify here with red crossed out edits is that it was really important to me to ensure that consumers could have opportunities to directly edit our outputs. So as we iteratively developed the triage document, it wasn't enough just to share, but I felt like it was really important to make sure that they could edit those documents directly and change without having me or someone else trying to interpret comments or discussions, letting them, if they wanted to, not everybody wanted to, but allowing people to edit things directly, I think is really powerful. And that's something I do, not just when engaging with consumers, but any collaborative work that I do. I think it's really important to create that opportunity. And the final sort of take home was for me that it was really important to emphasize diverse inclusion. I think, I did mention that there were 26 different groups who participated and who collaborated and who engaged with this. And it was really important to make sure that we were engaging people who would be impacted the most by these processes. So, for example, people with disabilities, older adults, and one area that I wish that we'd been able to do even more of was engaging with Aboriginal and Torres Strait Islander people in this process. But yeah, I think you get my point, which is diverse inclusion, and particularly inclusion of people who are impacted by whatever it is that you are doing on, I think is key. All right, I'm sure I've probably gone over the time I allotted myself, so I'd best move on. But thank you, and sorry, I'm just trying to stop my share. I would love to hand over now to Anthony Brown, who heads up Health Consumers New South Wales. He'll talk a little bit more about the context of New South Wales, and it's very interesting and in many ways very different to the Australian Capital Territory context. I might hand over directly to Anthony to explain and get started, but thank you, Anthony.
Anthony, we can't hear you. Please unmute yourself. Thank you.
Yes, no problem. So thank you so much for that great introduction, Brett, and for really helping to set the scene with consumer engagement and those really important principles. So I'm assuming people can see my first slide there.
Yep, we can.
Right. So thank you so much. As Brett said, before I start, I'd also like to acknowledge the traditional owners of the land that I'm on today. I'm on Gadigal land, which is in central Sydney, and I pay my respects to elders past, present and emerging, to any Aboriginal or Torres Strait Islander people that might be joining us this evening, and to any First Nations people who are joining. My name's Anthony Brown. I'm the Executive Director of Health Consumers New South Wales. I've been in this role for nearly 7 years now, and before that I've worked with a number of consumer and community organisations in New South Wales, as well as spending 10 years as a researcher at the University of Western Sydney. So for people who aren't familiar with Health Consumer New South Wales or organisations like us, and I thank you very much, Brett, for that introduction to consumers and talking about some of the language that's contested about that term. But as you said, we're not here to talk about that tonight. So Health Consumers New South Wales is a peak organisation for people who use health services in New South Wales. We're part of civil society. We're not a government organisation, although we work very closely with government entities. And we work really hard to ensure that the voice and experiences of people who use health services reflected in the development of services, policy, and more recently, that people are involved in health and medical research. So the discussion today is looking at what's happened with COVID-19, in particular the response to COVID-19 as it happened in New South Wales. And I just want to, I suppose, draw people's attention to this document that we found very useful early on in the pandemic that was put out by the World Health Organization, UNICEF, and the International Federation of the Red Cross and Red Crescent around guidelines for government primarily, but for health services in how to connect and communicate with communities, but also how to involve communities and people who use health services in their planning for the COVID response. Brett mentioned social justice as one of and justice as one of the reasons to involve people, and it won't surprise people that the World Health Organization used the language of rights and made it quite clear in this document that people have the right to actively participate in the response process and the design of the response process. This is the full quote, and if people want to read that, they can look at the document, and I'm very happy to make these slides available to people afterwards. For people who aren't familiar with New South Wales, and I understand we've got an international audience and lots of people joining us from various countries in the region. New South Wales is one of Australia's state, and it's the area that's shaded there in red on the map. It's quite a large place, slightly over 800,000 square kilometres, and we have a population of 8 million people, which is 30% of the Australian population, and 5 million people are located in Sydney, in our capital city. We have nearly 3% of the population who are Aboriginal and Torres Strait Islander and background, and I think what a lot of people don't realise is that Western Sydney has the largest population of Aboriginal people in the country in any regional area, and 25% of the New South Wales population speaks a language other than English at home. So we're a very diverse population that's spread over quite a large area. 80% of our population lives along the coastline, and for people who are living inland, there can be quite large areas. There's a lot of areas that are remote and have very limited health services, and people have difficulty accessing health services. The health system in New South Wales is provided primarily through public hospitals, and they're organised into 15 local health districts. That sort of level of detail is probably not needed here, but all of those public hospitals, and there's something like 220 public hospitals and health services that are government run in New South Wales, and all of those are required to show in some way how they partner with patients through an accreditation process. I'll be talking today about the COVID response that was planned through the public hospital system and the public health system in New South Wales. I won't be talking about GPs or primary health. By GPs, general practice or family medicine. Primary health care is mainly funded by the Commonwealth, and I think that's a complication that maybe is too much to get into for this webinar. So what happened in New South Wales? In New South Wales, as I said, there's those 15 health services, and overarching the health services is the New South Wales Ministry of Health. And the way that things normally work is that health services have a reasonable amount of autonomy in order to respond to local need and local communities, and the health service, the ministry, set some policy and guidelines. What happened, quite understandably, when COVID hit was that a lot of the planning and the control was devolved to the central government, to the ministry. And the ministry organised how it responded by forming what were called communities of practice. And these communities of practices were groups of people, practitioners, clinicians who had clinical expertise in different areas, and they planned responses around those particular areas. I've put up here a diagram of those communities of practice and how they were organised. It's not particularly important that people know the detail of that, but just to see that it was quite a centralised response. Now, the consumer and community engagement on those communities of practice was not mandated. A few managed to have consumers and community members embedded in them, but not many. That really was something that happened after they were formed, with organisations like ours encouraging the ministry to make sure they include relevant community and consumers to be part of those decision making. Health Consumers New South Wales was a member of one of the communities of practice, and that was the non-government organisation community of practice, which was very useful, but we weren't there. We were there because we were a community organisation, not because we were necessarily a consumer organisation. So we weren't there to explicitly provide consumer view or consumer experience, although we did that every opportunity we got. So what happened in some of those? I mentioned there's over 200 hospitals in New South Wales, and most of those hospitals have some form of consumer involvement using those principles that Brett was talking about embedded in them. They could either be through, most often they were through structures like consumer or community advisory committees, where members of the local community were advising the hospital about what's important to the local community, and that's sort of part of the hospital's planning and governance processes. Or they might have consumer representatives and people with sort of various relevant lived experience sitting on important committees within those local hospitals. That's something that's been developing for almost 20 years. Some places have very well embedded and really good systems in place for consumer involvement. Unfortunately, what happened when that centralised mechanism of planning a response to the pandemic was put into place, unfortunately what happened at a local level was a lot of that great consumer work was suspended. At first it was because people didn't want, quite understandably, people wanted to restrict the number of people who were coming onto hospital premises, and then as we went into lockdown, it was about not being able to have meetings, like physically meet up with each other, but also it was because the specialist staff who were engaged in bringing consumer engagement and making it happen within those health services, a lot of them were redeployed into other aspects of the pandemic response, into things like contact tracing and those sort of things. And so that had the effect that, particularly at a local level, these good structures that were in place for consumer engagement that normally happen, a lot of them were wound back. And it also meant that great mechanism wasn't utilised as part of the planning for a COVID response. Later on in the pandemic, thankfully, connections with local communities were actively sought and re-established, which was a wonderful thing to see. That was mainly in response to low vaccination rates in certain populations in certain part of the state. It worked very well, but it was that process of engagement was, in my opinion, put into place a bit late in the piece, after problems had arisen, and problems that I don't think would have happened if those communities were actually involved in the planning from the start. So what did we do at Health Consumers New South Wales? Well, what we did was we actually tried to put mechanisms in place where our members, who are those health consumer representatives who are sitting on those hospital advisory committees and health services advisory committees, we tried to put things into place so that we could hear what they were doing and what their concerns were, and to make sure that they were heard and taken into account by government. So we formed a couple of we called them Consumer Task Force. We had consumer leaders from around the state who came together and were advising us on what was important. We also have strong links with local sort of consumer organisations who are some of the disease and population specific groups, and we formed a task force of representatives from them as well. And they were able to tell us about their concerns, and through our involvement with the community of practice, we were able to feed that up to the ministry. So we actually were able to play a good role in facilitating some communication and two-way communication between the people organising the response and various consumer groups. And it was something I'm very proud of, but we had to go knocking on the doors to make it happen rather than the doors opening and us being invited in. Part of the response that people identified was concerns about two things: visiting policies. People felt that people were being unnecessarily denied being able to visit their family who were in hospital, and people who may have been in hospital not necessarily for COVID, and also around the use of telehealth, which was something that telehealth and virtual care really took off over the past sort of 2 years in Australia, which was great, but we were concerned that, again, this great way of delivering health services had been developed with not a lot of consumer involvement. And we also, as an organisation, really looked at how we talk to our own members and engage, and we developed new ways of engaging with people online, using online technology, connecting with people through things like Zoom and Microsoft Teams, but also through a specific new online engagement platform that we developed that we called Amplify. So this is, Brett mentioned that we put some tips together for services to work with consumers. Those tips are available on our website. There's the document that I think Brett mentioned, and I have to acknowledge that we're very proud of that document, but we did base it in part with work that colleagues in Queensland had done, and there's a link there to some of the other tips. So one of the things that we're doing now is actually we're working in partnership with colleagues at the University of Wollongong, and we're asking consumer representatives, those people who are sitting on consumer advisory committees and community advisory committees, about what their experience was like in the past couple of years. Because, as I said, what I've presented today is my feelings and where my reflections on the past couple of years. But we want to actually talk to people on the ground about their experience and bring some evidence together about what's happening there. And those interviews are finished. The data analysis is underway now, and we plan to publish those findings next year. My alarm clock's going off to say that that's my 15 minutes, which is perfect because here's my thank you slide. So thank you, and I didn't start by saying thank you to Brett and the colleagues at ANU for inviting us to be part of this great discussion tonight. So thank you. That's my presentation, and I look forward to the discussion.
Fantastic. Thank you, Anthony. I'm sure everybody's doing a virtual round of applause to thank you. So it's now my pleasure to introduce Darlene Cox, who is the Executive Director of Healthcare Consumers Association, ACT, and has been in that position since the incorporation of HCCA ACT in 2008. So I'm looking forward to hearing some of the differences and observations about consumer engagement in the Australian Capital Territory. Thank you, Darlene.
Thanks, Brett. Actually, our organisation was incorporated in 1978, but I've been there since 2008. Can't believe all those years have just passed me by. There's no slides for me. You just get to look at my COVID shaggy hair, because there's still another 3 weeks before I can get into the hair cutter. Such is the demand. So thanks very much for the invitation to speak tonight. My name's Darlene Cox, and as I said, Executive Director of Healthcare Consumers Association. I'm on Ngunnawal land tonight in the ACT and pay my respects to elders past, present and they're emerging leaders. So Healthcare Consumers is the peak advocacy organisation in the Canberra region on health matters. We advocate for consumers on health issues. We're a community group made up of like-minded individuals, about 160 of us, with more than 30 organisations. We all share an interest in high-quality healthcare that meets the needs of consumers, and we're funded by the ACT government. One of the things we do is train and support members of the community to become consumer representatives and provide consumer perspectives on healthcare. And currently, we have around 50 reps on 180 committees at the local and national level. We also undertake research projects on the consumer experience and expectations of healthcare. And for over 40 years, we've been the critical friend of governments and provided insights. Since March 2020, with that first wave of the pandemic, we've worked really closely with health services in the ACT to develop the clinical response. Our organisation's committed to that principle of consumer empowerment that Anthony and Brett both talked about, and that means that we want people to be in charge of our own health. We're also very focused on the delivery of safe, high-quality healthcare, and we want a system where consumers are actively involved in decision-making and we're supported to ask questions so that we can make good decisions. We need to have our questions answered in a way we can understand. And that's the approach that we applied throughout COVID. And tonight I'm going to share a few reflections on that, not only from a consumer perspective, but also from community perspective. I'm a member of a committee called the Clinical Health Emergency Coordination Centre. Now, Brett alluded to it earlier as the COVID task force. So very early on when it started, I was approached to join that. So I've been for more than 18 months now intimately involved in the clinical response. Its members are senior leaders of the public health system, hospital system, and my role specifically is around consumer perspectives and NGO and community liaison. So I spend my days and nights talking with consumers and community organisations about their experience of COVID, what their needs are, and how we can make sure that those needs can be met. The pandemic for me has really underscored the importance of thinking about systems and processes in terms of people. So it's the people who deliver the care, the people who provide the testing and the vaccination, the logistics folk, the drivers, the contact tracers, all of those people who are behind the scenes making it happen. The pathologists have been amazing. I don't know how they've managed to get through all of the tests and the swabs that they have, all of the people who have been moved to other areas for the testing collection. It's been a phenomenal effort. And of course, I'm talking about the people who use services and our families and our friends. So COVID's underscored the importance of the voices of experts in public policy in developing a response. You can't just lock people in a room. You actually need people who know stuff. Misinformation has clearly been demonstrated to be highly dangerous around COVID. And I think the public health and infectious disease physicians and microbiologists, epidemiologists, they've really been at the forefront of the public policy debates. And in the ACT, we've done really well not to politicise it too much. The direct and early engagement with the specialist local community organisations in the development and rollout of any public health campaign is really important, and I think we've done that pretty well. We had a bumpy start, but now we understand why that's needed. The expertise that rests in community members and community organisations has been recognised, and we've really developed and built on those relationships and established strong collaborative practice. I think that it's been demonstrated in how the government's responded to the pandemic and the needs of multicultural communities and those people who are living with significant disadvantage, those who might be in crowded homes or have unstable housing, the people who have very low incomes and have lost work because of the lockdown, and those who have issues with addiction. We're focused very much through an equity lens on the needs of those people who are more likely to have poor outcomes if they get COVID. And we need to play a part to ensure that no one's left behind. It is all of our responsibility to do that. The response in social and public housing in the ACT has been a really good demonstration of the importance of working with community organisations, and so that we can understand the challenges the people who are living there face. And we need to hear the voices of the community leaders and the community members so we can understand the issues. You can't solve a problem if you don't actually understand what it is. You can't make assumptions about what people need. And we worked with those people. We introduce people that they trusted so that they could then disclose personal information to give us greater insight. You really have to challenge judgment and stigma that many people face in their lives. Organisations like CARMA, and in the ACT, that's the Canberra Alliance for Harm Minimisation and Advocacy. They're our drug users support group, peer mentors and educators. And it's long been recognised as a public health, a significant organisation for public health reasons. But, you know, during this period, the peer support that they have provided has made such a difference in helping people feel safe, talking about their needs in a non-judgmental way. It's helped them safely quarantine. It's helped them to get the care that they needed and the support they needed. Directions Health Service is an NGO health service, and it specialises with people who have alcohol and drug issues, and their general practitioners and practice nurses and other support staff have been amazing in providing care to tenants. They've been providing a service of rolling out vaccination to tenants of public housing, social housing, and also clients of homelessness services. Another interesting one where we all came together was around the establishment of the Access and Sensory Clinic. It's shown how you can partner with consumers and carers and advocates to respond to a need. So this is a clinic that provides vaccinations for people with disabilities, with mental health conditions, and those needing additional support in a quieter, less rushed, more accessible venue. And the vast majority of feedback that we've received about the clinic has described it as being a positive and supportive environment. And my colleagues at Carers ACT have heard numerous stories of staff going above and beyond to make the vaccination process as accessible and comfortable as possible. They even closed down parts of the clinic, vaccinated people in cars, and took long periods of time just to comfort people who are scared of needles. And so I think the flexibility and compassion of the staff face-to-face at the clinic, answering the phones and developing the services behind the scenes really should be commended. That's about meeting patient needs, and that's pretty amazing. The collaboration really has been at next level, and what we're keen to do now is actually bring that spirit of collaboration and inclusive access forward, and let's maintain it in future health service development and policy work. Communication's been really important as well during the pandemic. We all know that. But at the same time, you can't forget that consumer issues like informed consent, the involvement of family and friends, feeling supported to ask questions and have things explained to us in a way we can understand, like these things are still central to high quality care. And just because we're in a pandemic, that can't stop. Just because the health services are working at pace, you can't stop doing that. We were constantly reminding people that they still had to use the telephone interpreter service, and the translation of materials into community languages was still really important. We advocated for the ACT government to develop materials to meet the information needs of different communities. And I think it was done better this outbreak than at the beginning of the pandemic. There were regular newsletters, webinars, Q&A sessions for community members and community workers. Social media was a really important communication channel. So I think the ACT government and our health services have responded much better this time round. For starters, most of us know how to use Zoom now, which, at the beginning, we're all a little bit lost in the moving to a virtual platform. The other thing around the consumer experience is that the way we access care has changed so significantly in the pandemic. We've seen an increase in the use of telehealth. Now, it's been an effective option to reduce the transmission of the virus, which is great, but it's been that whole digital health agenda has been held out to us as a way to transform healthcare and improve consumer outcomes and experience for years. So it's really good that COVID's been wonderfully disruptive and helped to advance it. We can phone a GP for a consultation, get an electronic script sent to a pharmacy of our choice, and they can deliver it, albeit with a cost. Telehealth doesn't work for everyone, we know that, and it's not a replacement for face-to-face consultation. So we've continued to advocate for options for those people who do not have the technology or the skills to use the technology to access telehealth appointments. I think the other significant impact for consumers has been the experience of care, in terms of experience of care, has been the visitor restrictions. So the restrictions have been really hard, but we've had to make those decisions because it's about people keeping people safe and designed to prevent the spread of the virus and maintain the workforce. In the ACT, we've got one tertiary hospital, one really serious teaching hospital that deals with a sort of 800,000 people and through southeastern New South Wales. We actually have to look after that staff because if they get sick or if they're furloughed or if they're an exposure, then we don't have the staff to deliver the service. So it's been a really delicate balancing act. But it also has unintended safety consequences for patients because if we don't have our family and friends in the room with us, we might be more at risk of falls, not being able to eat our food or drink, or there might even be delayed recognition of deterioration. And one of the areas I'm interested in researching is, did we in fact see a change in adverse events during COVID? Close family and friends are an essential part of our healthcare teams. They're our patient safety monitors in many ways. Now, the consumers and our carers accepted the restrictions, but in return, we wanted assurance that staff were able to involve family in bedside handover, in discharge planning, the medical rounds and other important interactions via technology. And it's not been as smooth as we needed it to be. This takes time and planning, and I think the staff are already under significant pressure and it made it harder for them. We're very focused on health literacy in our organisation. So I mean that by health literacy, I mean people having the skills, the knowledge and the confidence to find, understand and use health information, be active partners in our care and navigate the social and healthcare systems. Across our communities, if you reflect on it, we have really increased our level of health literacy. You just got to look at the language of the pandemic that all of us are now using around flatten the curve, surge capacity, PPE, double dose, TTIQ, epidemiology, breakthrough infections. Like people are starting to use those in regular conversations. So I think communities are now more attuned to health messages, and that's an opportunity for us to build on going forward. Many of us have also listened to the public health messages. We're maintaining physical distance. We're finally washing our hands properly like our mothers always told us to. We're wearing masks. We're checking exposure locations and using check-in apps. And many of us have tuned into the daily press conferences and check the social media for updates. But there's still more to be done. I think we still need to know more about the disease. And I don't mean as clinicians, but I mean for us as consumers to actively manage our health. We need to know what to look out for. We need to know what the symptoms are, when to get tested, when to isolate, when to call the GP, or when to call the ambulance and go to hospital. We need to know the signs to look out for in terms of deterioration and what our options are to escalate. And asking questions, I think, has never been more important. So my final point touches on the power of evaluation and reflection, which is often undervalued, and I think even more important in times of crisis like now. I've been encouraging all of my colleagues to take the time to think back on what's worked well and what consumers need to change in order to improve our individual and collective responses to this situation. And I encourage all of you to take a moment and reflect on what's been happening. Think about the changes that we can make to make consumer participation stronger, to be supporting consumers to be more active in care, and what you can do to keep us safe. And so I think, honestly, the way we've mobilised and responded to a significant threat has been really good, in fact, amazing. And I've been very privileged to have been in a position where I can represent consumer and community interests at the decision-making table. I can only hope that we start to apply the same focus to responding to climate change. Thank you.
Thank you, Darlene. Very, very pertinent message to leave on there. That's very insightful. Thank you. I wish that I had shut myself up earlier because I realised that I haven't left a lot of time for questions, but there are just and I noticed that there are some that are answered there in the Q&A box. But I did also just want to very quickly, because there's a couple of pertinent questions that been left open, and I thought it would be great to get Darlene and Anthony's perspective on the two questions that are still open there in the chat. So the first one is around whether there's been any feedback about translating COVID-related educational resources to other languages for culturally and linguistically diverse populations, and what has that been like in your respective areas?
I'm happy to talk about that because we've done quite a bit of it in the ACT. ACT has a really strong multicultural community and well-connected organisations. And I think because we've got a population of 450,000, it's just sometimes a bit easier to talk to the right people to get the messages out there. Still, I think sometimes we struggle with translating things not only in language, but also a cultural interpretation or cultural translation. So the feedback we've had through the Office of Multicultural Affairs and through my colleagues in multicultural organisations is that last year it wasn't so good. For example, the food in the food packs wasn't culturally appropriate, but this year we've done so much better because of the feedback. So consumer feedback does make a difference. We're getting the right links with communities, therefore we know what to be able to provide for them, and the information needs are being met.
Look, there's not much I can add to that. We weren't directly involved in a lot of those discussions. What I've heard is, in terms of the timeline, for most of 2020 and early 2021, the connection with multicultural communities wasn't as good as it had been. And again, I suspect there was some stepping back from some really good local connections that had already been made. There was some great work that was done in Western Sydney and by researchers at University of Sydney's Health Literacy Hub that interviewed and spoke to people living in Western Sydney in a number of community languages. And I think that really helped show some of the, not just the misinformation, but some of the barriers to getting information out to some of those communities. And through work that happened with community leaders and connections that, as I said, I feel there's been a real effort to reconnect with those groups more recently, and I think we've seen some of the results. But it was slow in happening, and when it did happen, it was in response to a problem. It wasn't about proactively making sure that those communities are receiving good quality information from the start.
Thank you both. And then the final question that, again, I'd like to pose to you both from your respective jurisdictions and consumer members is in the context of COVID and the way that telehealth has become such a, I guess, mainstay of the way that we're currently accessing health services. And obviously there's pros and cons that come with us. What have been some of the initial reactions of consumers in the ACT and New South Wales around telehealth as it's evolved in the last little bit, and do we want that to continue post-COVID?
Yeah, we absolutely want it to continue. We've been wanting it for a long time, and so this is where the disruptive power of COVID has to be embraced. Look, it's mixed. Some people, if you've got the skills and you've got the resources, the capacity to engage in that way, then it's actually been very good for people. They have talked to us about really missing the establishment of the rapport or having the time. Telehealth is quite transactional in its approach, and so they have missed that human interaction with their trusted clinicians. Sadly, though, what we found is that we put a lot of energy into supporting consumers to use telehealth last year, but the minute the numbers started to decline, clinicians reverted back to type and wanted people to come and see them. And even though that wasn't what consumers wanted the option, a telephone call or a teleconference or a face-to-face, because sometimes, and if it's really about consumer control and consumer choice, that has to be offered.
That's entirely consistent with what we saw in New South Wales as well. We spoke to our Consumer Leaders Task Force, identified telehealth as one of their two main priorities during the pandemic, and visiting policy was another one. And Darlene spoke about all those issues so eloquently in her presentation. People really appreciated the convenience of telehealth, particularly people who have to travel a long distance to see doctors. And that's not only people in rural and remote areas, it's some people in large cities, people who have mobility issues, people who are carers or have childcare responsibilities. So people really appreciated the convenience. People absolutely understood that it wasn't for every person for every consultation, and that there were still times when physical examinations or something is needed. And consumers also told us they miss that rapport, and that sometimes they miss some of the non-verbal communications actually from doctors and practitioners that face-to-face offers. But on the whole, people definitely wanted it to continue. And one of the things, of course, is that I think it also really highlighted the digital divide, and that there are many people who are living in parts of New South Wales that don't have access to reliable broadband, and many people who can't afford, even on a mobile device, broadband. So when it came to those video consultations, that was definitely an issue. But people definitely want to see it continue. But also people were really adamant that while they wanted to see it continue, telehealth could never be seen as a cheap option or an excuse to get rid of services. And there were people in rural areas who made it really clear they loved the convenience, but they also knew that they needed and wanted to keep things like good and reliable patient transport. There was, local community local hospitals that they could easily get to, and there wasn't a winding back of any local services. So telehealth is, from a consumer perspective, was always needed to be an adjunct rather than a replacement. But people definitely wanted to continue.
Yeah, thank you both. I think that's incredibly insightful.
And sorry, just a bit of blatant self-promotion. There was a question in the question and answers, and I've just popped a link to our report on what patients told us about telehealth if people want to have a look at that.
Thank you so much, Darlene and Anthony, for spending your time. I'll hand back to Devashi to close, but I just wanted to personally say that was incredibly insightful. I learned brand new things from you both tonight, so thank you.
Thank you, Brett. Thanks, Anthony, and thanks, Darlene, as well. I completely agree with Brett. Learned a lot. Thank you for your excellent talks, and absolutely amazed at the massive efforts you and your organizations have put in. It really highlights how crucial collaboration with service users, community engagement, and etc. have been during the pandemic. So, and your perspectives from both the ACT and the NSW, it was very informative. And thank you for answering all the questions, typing them up and keeping on top of them. Really appreciate that. I'd like to just quickly wrap the webinar up now. And thanks to the attendees for joining in. Again, it's been very engaging with all the questions that you've put in to the Q&A box. So just a quick note on the next webinar, which is about lessons learned from the ICU during the pandemic. And this will be delivered by Professor Swapnil Pawar. A quick note on the ANU COVID-19 peer support program as well. You can find more information on our website. And if you're a medical or healthcare professional, you can also register to volunteer or seek support during this link. And you can also contact us via email for any questions regarding the program, webinar series, or this talk. So thank you again. And that's it. Yeah, we will be signing off now. Thank you all.